Okay, I'll just take this one off. Now there is possibility to ask questions. The idea was that we invited a person from ECDC to participate also, because we think this is relevant for ECDC. But we were just informed that they were not able to participate. But you can ask questions to Tamara and me, and I also think that Palle Valentina from State and Serum Institute should be online. He is an expert in vaccine preventable diseases and in vaccine coverage. So if anyone wants to ask questions, you are welcome. Palle, do you have any comments if you are online?
Yes, thank you very much for this really interesting presentation. And I think what you have presented is really important way that you have been able to distinguish between just what is the coverage for the individual birth cohorts, but also that you are actually looking into the delay of vaccination and the expected delay of vaccination, because as public health institute working with the performance of the vaccination program, it's really important to be able to identify rapidly things that are happening where you are creating unexpected delays. As you showed with the results from the Netherlands, where it was a planned delay, but you could clearly see it, but you could also have these unplanned delays. You can, for example, have a vaccine scare. Maybe you can have a breakdown of your vaccination system, or you can have a failure of vaccine delivery and stuff. It is really important to identify this early in order to correct it. So in that way, you are moving from a system where you have some delayed information about what is the actual uptake of a birth cohort of a vaccine, to a system where you can almost real time identify these unexpected delays, because you are comparing to the expected delay of the other birth cohort. So that is really data for action, and I think that is a really huge step forward to have this way of looking into the speed of vaccination as well. We had a problem, for example, in Denmark some years ago, where we had a HPV scare among the population, and we could also use this method in order to detect very early some delayed vaccination, and we were able to try to respond to this crisis. So this is my take on this. Really good to have two different ways of looking into the vaccination uptake. Thank you.
Oh. Then I would like to ask the participants here, because now it was Denmark, Finland, and the Netherlands who provided data. And I can tell you that we had contact with the different countries, and we talked about how to install the R program, how to prepare the vaccination file so that you could run the coverage estimation. And as soon as that was up running, I could send an email to Finland and Netherlands saying, could you please extract data tomorrow and provide me with some coverage estimates? And they could. It took very short time. So would any countries be interested in providing data to this platform or a similar platform? Søren?
Il faut prendre un micro, merci.
Maybe.
Thank you. well, Sweden should have provided, and we made some efforts, and partly I think due to the COVID pandemic and the people in charge of the registries and so on did not manage in the end. But with the work that has been done, I think we really should make an effort to try to continue. I think that is the challenge now for the future, because we have this tool, not just to leave it there and not to use it. So how do we take it to something that is used in the future also? Thanks.
I think maybe it is not necessary that every country, all countries start to providing from the beginning, but it would be nice if countries would sign up for such a thing, because I think it's a really valuable tool. At least we learned a lot when we looked at data over time.
Good morning, I'm Karianne Johansen from Norway, and we really looked into delivering data to your platform, but when we were very uncertain if it was indirect identifiable data, we had to run through our security systems in the surveillance registries. And I think that was a bit confusing for us, what kind of data you ask for and what should be delivered. And we also have our own rules too. For instance, when we calculate measles coverage, we really have very distinct rules in our childhood immunization programs. And we have our official statistics, and we don't want to have two different statistics, one European and what is actually deviating from the Norwegian one. I think that was our issues, and that's why we didn't deliver data to the platform. Thank you.
I think you can use maybe the R program just to check the consistency of the data that you would then provide to the platform. Maybe that would be one of the ways, and it shouldn't be two different data, it's the same data. Also, regarding what kind of data, it's aggregated data, of course. I mean, for running the R code, you can also use individual data, but then again, the output is aggregated. So basically what you have is a birth cohort, age in months, and number of children and number of vaccinated children in that group. So this is something that is not identifiable in ways that should be problem to, I don't know, GDPR or something.
Hanna Nonek from Finland. Thanks a lot for excellent presentation. My concern is the sustainability. ECDC is collecting coverage data for all the childhood vaccines and hopefully also the adulthood vaccines in years to come. How are we securing that what you have developed actually is being maintained and used, and issues like what was raised by Norway are solved? Because most issues are solvable. It's usually a question of understanding and dialogue. So how do we make this sustainable?
I can start answering, and maybe Hanne Dorte can fill me in if I said something wrong or missing. So for now, we have secured the sustainability of platform for next 3 years, which is short because then it's still not sustainable. And we wanted to discuss, we were in some discussions with ECDC representatives, maybe to take parts of our platform and integrate it in their systems, because we are aware of the ECDC Atlas of contagious diseases, and we are aware that in the meantime, after we already started the project, they've been also developing their own maps. Now, what we think that could be integrated from our project is one, it's the R code, because it's really simple to use. And of course, then you don't have to upload the data on the platform. It is good because then you can see the cross coverage, cross borders coverage, but you can use it to run locally, which is really good because then you immediately see, you don't have to upload anything. So this is one of the things that we would like for the ECDC to consider. that it is really user-friendly, and you don't have to upload it necessarily somewhere, but you are kind of in charge of what you want to see and what you want to get. And the other thing is that we have NUTS levels 3. So our maps currently are more detailing in compared to what ECDC has, its country level. So we were discussing, these discussions are still not over, and we hope that they will recognize the potential and probably take some parts of our platform and the code and then adapt it to suit their own needs, and maybe that is kind of securing the sustainability.
If I could just add that exactly what you're saying, Kajana, about that you have your very clear definition on how you estimate measles coverage. Maybe that's also one of the problems that we face, because you will never get real time, or you will if you estimate in different ways, it's extremely difficult to compare between countries. So you can say, if you want to find these gaps or you want to act on them, then I think you need a comparable way to estimate coverage. But I think maybe I didn't make it clear during my presentation. What I presented was the output from the R package. So Finland and Netherlands, they sent me the output so I could sort of prepare the report. So this was what from their local aggregated data so you get exactly the same output as is on the platform. So you can run it and look at it at your own computer. You can see, is there something strange here? So I think it's a good idea just to try it, to see how it works, and then see if you would be interested in working with it. I don't know if there is any representatives from ECDC or WHO who can comment on it, but
in the meantime, maybe I have a question regarding the reminder systems. After doing this survey in Europe, what would be now your best definition or your recommendations for the best system of reminders? How does it work? How does it contact people? Is it for every age, the parent of the small children and the elderly and the adults and so on? What would be your recommendation for the best system?
I don't think I can say what the best system is, but what some countries responded was that if you want to reach remote, maybe populations that is in poor areas, they will not have an internet connection. They might have a phone. They also said that it is cheaper to receive SMSs. So SMS is or text messages is important compared to a phone call, which is more expensive. So things like that, I think you need to consider in your country. So it's not, I don't think there is a best way. I think, and this is what all the literature I've been through said, that it is important to tailor your program so you reach the population that is, but you of course you need to be able to identify the populations, but it is important to be that they accept the messages you send about vaccination, and maybe also if some areas you need to contact them or visit them or something else, then I think this is the important way, that you really tailor your reminder system to reach as many as possible. Sarah?
Hi, thank you so much for a really interesting presentation and discussions. It's just bringing up quite a lot of issues that we have looked at in the cross-border vaccination campaigns that we'll come on to in a minute. But I think that at an international level through the system, it's possible to identify areas of lower vaccination coverage. And I think also through collaboration and sharing of best practice, it's possible to identify, key characteristics of reminder systems that are useful and that work, and that can be shared across borders. But I think from the discussion it's also, and from the literature that you refer to, the actual application of the intervention then really has to be designed locally or at the level that the program, the vaccination program is organized, or even more locally in the case of sort of low vaccination groups and populations that need these sort of very tailored interventions. So there's several levels of complexity in this. And I just wanted to sort of emphasize that part, that it's really good that we start talking about this, and there's so much that we can do in terms of collaboration across borders for sharing the best practice and the best knowledge from the literature. But I think that there is still this place for kind of the locally implemented interventions that are at the same level as the vaccine programs are implemented. So it's not a one-size-fits-all approach.
Just maybe for a last remark, I can say that one of the things that surprised me was that very few countries is actually translating their reminders. Maybe it's not necessary. I know in Denmark we are translating to a lot of different languages to reach population that is not born in Denmark but live in Denmark, where it can be difficult to reach to receive letters from the public like saying you have to get vaccinated. How do you understand this? So this was one of the things that surprised me, that few countries reported that they translate their reminders.
And we have a message on the chat from the ECDC from Tarek Derouf saying, thank you for the presentation. Since the onset of the COVID-19 pandemic, ECDC had developed a tool to monitor COVID-19 uptake, the COVID-19 vaccine tracker available online. And they are planning and strongly considering to use this tool to collect and display uptake for other vaccines and vaccine coverage. This also in light of the ECDC new mandate to engage further into coverage monitoring. We are grateful for the work done by the JAV in this regard, and the experience gathered will be necessary. We hope to have further discussion with the specific work package leaders, and Daughter and Tamara, and again, apologies for not being able to be with you and to intervene, I understand. But thank you for the mention. So I expect indeed some discussion to, as we were already saying, to occur between us and the ECDC in the near future.
Great.
Thank you.
Okay, there is maybe a last question also in the chat. It's not easy to resume, and I think it's even more difficult to answer. But how do you see that COVID-19 that has cast a light on such a platform? What are your reflections concerning such a platform regarding vaccine coverage, COVID-19 vaccine coverage?
You could set it up for vaccine, COVID-19 vaccine coverage. Of course, you will have to change the tool behind it, because now it's measles, so it's 2 doses. If you have a COVID-19 vaccine, you'll have 1, 2, 3, 4, 5, 10 doses maybe. So you'll just have to set it up, and it's not so much birth cohort related, it's more population related. So you'll just have to rethink the sort of the algorithm, but you can set it up for any vaccine in principle.
Okay, I guess. So thank you. Thank you, and Daughter, and thank you, Tamara.